Hi, my name is Sarah Tamzudeen and I'm a resident at Scripps Green Hospital in San Diego. Today I'm presenting a rare case of CNS Nocardiosis in a patient on high-dose steroids. Nocardia is a rod-shaped aerobic bacterium that's weakly gram-positive and partially acid-fast. There are over 80 species described, about half of which have been shown to cause disease in humans, mainly in immunocompromised patients. Our patient is a 52-year-old female who presents with 3 weeks of progressively worsening positional headache and nausea, followed by an episode of acute confusion. She was in the kitchen trying to make breakfast and forgot how to use the toaster or where her frozen waffles were. Her past medical history is significant for hypertension, DVT on Eliquis, and systemic lupus erythematosus, for which she's been on prednisone for many years. She also had a hospitalization last year for severe vasculitis of the right lower extremity, leading to a below-the-knee amputation and prolonged recovery period, during which time she had stopped her prophylactic Bactrim, though she continues on both mycophenolate and prednisone for lupus. On exam, her memory had improved and she was ANO times 4. Cranial nerves 2 through 12 were intact outside of left uvula deviation, which was thought to be at her baseline. Her strength, sensation, and reflexes were also intact, though she had a chronic left foot drop and right BKA. Her initial labs were non-diagnostic, but CT head showed 2 large densities with prominent edema in the right frontal and left parieto-occipital regions. Follow-up MRI confirmed these ring-enhancing lesions post-contrast, consistent with either CNS lymphoma or a pyogenic brain abscess. Neurosurgery recommended biopsy after holding her Eliquis for 5 days. Antibiotics were held initially, but she developed fever and altered mental status in patient, and empiric ceftriaxone and vancomycin were started. 2 days later, she underwent right frontal craniotomy with a resection of the right frontal lobe lesion. Frank purulence was expressed from the opened capsule, and she was brought into cefepime and flagyl. The cultures resulted 3 days later with nocardia nova, and high-dose Bactrim was added to her regimen. Shortly after this, our infectious disease team was consulted, and she was transitioned to combination therapy for a nocardia brain abscess with 3-drug treatment regimen. CNS nocardiosis is rare, representing only 2% of all brain abscesses. It may be misdiagnosed as a brain tumor, vasculitis, or even stroke. Clinicians should be up to date on treatment of this potentially fatal disease and have a high suspicion in immunocompromised patients who are not on the recommended PJP prophylaxis. Aspiration or craniotomy for lesions greater than 2.5 centimeters is recommended for speciation and susceptibility testing. Craniotomy and excision, as in this case, is more effective than aspiration and drainage, though obviously up to the neurosurgeon's discretion. One of our questions in this case was how to appropriately treat a nocardia brain abscess. Sulfonamides, like Bactrim, are still the cornerstone of treatment for nocardia, but Bactrim monotherapy is no longer recommended as there is increased mortality in patients on Bactrim monotherapy. Nocardia farcinica is an increasingly common pathogen that has high rates of intrinsic resistance to Bactrim and would therefore not be appropriately covered with just Bactrim. A systemic review of patients in Asia with nocardia brain abscesses recommended adding meropenem and a more aggressive approach, which had better outcomes in terms of mortality and morbidity than those treated with just Bactrim. A review of Israeli patients with nocardia showed a 1-year mortality of over 30%, and about a quarter of their isolates were resistant to Bactrim as well. Additionally, although Bactrim has good CSF penetration, it's bacteriostatic and may be more effective if used synergistically with another antimicrobial. Combination treatment with amikacin and imipenem, or meropenem, is traditionally recommended. However, there is increasing experience with linezolid suggesting that it is efficacious and may be preferred over amikacin due to amikacin's side effects. We put our patient on Bactrim, linezolid, and imipenem for 6 weeks. She had a good response with resolution of her neurologic symptoms and diminished size of the left parieto-occipital abscess. She is currently on consolidative oral therapy with Bactrim and doxycycline, which she will complete 1 year of. These are my references, and thank you very much for listening.